Sure. Well, I'd like to welcome everyone to today's webinar, and we're delighted to have a panel of guest speakers talking about nurses' mental health and experience of leaves of absence and return to work. So we have Abby Ayoub from the University of Ottawa. We have Bourgeault, who is from the University of Ottawa as well, Melanie Lavoie-Tremblay from McGill University, and they'll be speaking in just a moment. I want to reassure everyone that we will be recording this presentation today, and we'll be posting the slides and the recording for anyone who might have missed it or want to listen once again or share it with their colleagues. So we will post that.
I want just to comment and ask, you mean the entire presentation or the slides?
Yes, both.
Then I want to alert people that are asking questions verbally to be aware that we will post it, okay?
Yes,
so that we don't need to go and ask you. So just be aware that we will post it. And Paul Andre, to your comment that we need to remind people, actually we sent the tweet about 15, 20 minutes ago. Thank you for the idea. We did it, so yes.
Yeah.
Because people do forget, it's true.
And this is a sensitive topic.
So that's a fantastic idea, but please know we did. Thank you.
Yeah, great. So this is the overarching agenda. So opening remarks, Doris, a moment to give some updates on COVID-19 and health system transformation, any latest news or pressing issues, the presentation, questions and answers, calls to action, and then I'm hoping that we can reserve a bit of time like we've been doing at the very end to do a cheer with masks on perhaps at the very end. Okay, and then our speakers today have asked that we maybe leave the questions to the end, and they are willing to answer any outstanding questions after the fact. So I'll pass things over to you, Doris, for a few updates. And I just have one slide here, if you want.
Let me start where you left us, at the end. At the end, when we do the cheers with the mask, let me tell you the latest about that. So there is more and more evidence that masks actually make a huge difference, much more than what people even thought. And I don't know if my colleague, Betty, from the board is on the webinar, but Betty, you shared with the board a couple of weeks ago that you were concerned on what was happening in Chatham-Kent, and that people were not wearing masks and that things were starting to ramp up, and that you were concerned. You were right on, because Chatham-Kent at this point in terms of new cases is one of the, if not the highest in terms of new cases in Ontario. So you may have seen that on the weekend, when I became aware of that, I sent yet again a tweet talking about it's not either or, it's physical distance, it is hand washing, and yes, it is also wearing a mask in, you know where, public places that are crowded, in indoor places that are not your home, and in public transit. And then I took the opportunity to say to your mayor and your public health unit, time to mandate the mask, because Chatham-Kent is one of the highest, if not the highest, in terms of new per capita cases in Ontario. So it does make a difference. So it's good that we continue to show to others that it's not a big deal to wear the mask. With that, another update is the issue of reopening the schools. You may have seen that our Friday blog focused on that. And when you leave elementary schools without sufficient physical distancing, because you have full classes of 30 kids, you're not basically giving them a chance to have a break from the mask. And that's pretty significant, because everybody's saying in the province from grade 4 and onwards, masks are mandatory on the 3 places that I mentioned. And when you have 30 kids in a class, then masks are mandatory in the class. And many of the schools do not have air conditioning. Just picture young kids with a mask, right, in a classroom without air conditioning, saying that is happening in nursing homes, but these are children. So we did issue both the good news and the not so good news on reopening the schools. We are asking for smaller class sizes. And the good news is that we succeeded to have the government announce 500 public health nurses for schools. And we are now in conversations about ensuring that they are located actually in the public health units and embedded in those public health units locally. So more to come, and you will hear more. 2 actions to take, and again, I sent a tweet about half an hour ago or so, but also Madison, who is very, very tremendous for RNO with the Twitter. She's our Twitter guru. She has been sending all day. There are 2 actions. One is on the petition for class sizes to bring them down to half of it. And the other is to demand action on the nursing home basic care guarantee and start the hirings in August and not wait. More concerning even is that not only there is not hiring in long-term care, there is some firing in long-term care. And that I'm investigating all the way to the deputy and others. And that has to do either with governments with the nursing homes that have been taken over by other organizations that are managing them and simply do restructuring, which is not really necessarily the right time on a period that you will hear from Ivy and colleagues already stressful for nurses and others. And second, on homes that their volume has gone down, and because of that, they're doing some layoffs. So we're looking into that, and we will bring you more information. So I think those are the few things that I would like to share so people know the latest of the latest. We are doing all in all very good in Ontario overall in terms of cases going down, but not all communities are doing very good, and we cannot let the guard down either. So with that, maybe we pass it on to you, Ivy, to introduce your colleagues. So introduce yourself, Ivy, first, but I will do that. Ivy is the research chair in gender diversity and the professions at the University of Ottawa. And on and off, we have had a tremendous collaboration on research, on her research program, but specific research activity that she has been conducting for a long time and on very important issues given the nature of the nursing profession. And I will let you introduce Melanie. I also was involved with Melanie actually in research, not related only to Ivy, but I will let you introduce Melanie. And then Abby, with whom we also spoke a few weeks ago. And also, just so you know, RNO is supporting this research and will be engaged. And this is just part of that, so that you all have an opportunity to be engaged. Ivy and colleagues, just so you know, we are already at close to 150, and you can expect more people to come. So this is very exciting. All yours.
That's wonderful. Thank you so much, Doris, and I really appreciate the opportunity to present. And as you mentioned, this is my new research chair, which is focused as nursing as one of the professions and looking at a number of others. And that's what makes this project really quite unique. And we'll get into that in a little bit. But as you mentioned, I've done research previously looking at the health workforce and gender and the health workforce. And so this is a long-standing interest. And so we've collaborated for a number of years. This has been my first opportunity to work with Melanie. So I'd like to introduce Melanie Lavoie-Tremblay, that many of you know. who has done a lot of work in looking at occupational work lives and context for nurses. And so Melanie is one of the co-leads for our nursing team. So she's a associate professor at the Ingram School of Nursing at McGill University, and I'm very pleased to be presenting with her. And also one of the trainees for our team, Ayoub, who I'm very pleased to be both on her committee and to have her as a trainee for this project. Abby is a practicing nurse, registered nurse, and she's doing her master's degree in nursing at the University of Ottawa, looking at the most responsible provider around advanced practice nurses. And so very keen to have them both with me. I'll also mention two of the members of our team, Kelly Lackey and Sherry Price, were not able to be with us tonight, both at Dalhousie University, so they are members of our team. And Shamel Roll, who's also our trainees at the University of Ottawa, but she's basically situated in the Bahamas right now. So thank you again, and those are our introductions. So maybe we'll head over to the beginning of the slides, and I can just kind of to how we will start. I will present for approximately 10 minutes, giving you a bit of an overview of this large initiative that we're leading. Melanie will give you some background of some of the pilot data that we have, and then Abby will share with you some of the early preliminary results that we have from some of the initial conversations that we have, and we'll tell you a little bit more about how you might like to get involved, and so we will go from there. So yes, we could load up the presentation. That would be great.
So I thought you were seeing it. You're not seeing it?
No, not yet.
Oh, okay. Let me try. Sorry, I thought it was confirmation that you saw.
There we go.
Okay. Great. So you're seeing overview of the partnership?
Yes.
Great.
Yes.
Yeah, that's perfect. Thank you so much. So yeah, I wanted to tell you a little bit about the Healthy Professional Worker Partnership, and we're focusing on this case study looking specifically at 3 issues, looking at issues around mental health, leaves of absence, and return to work. And there's a lot of literature looking at leaves of absence and return to work for cases of physical injury, but less so for what we're calling mental injury or issues around psychological health and safety at work. So this is a joint initiative that's funded by the Canadian Institutes of Health Research and the Social Sciences and Humanities Research Council of Canada. And we are taking an explicit gender lens on this. And this is not just to compare men and women's experience, but to really understand the richness of men and women and gender diverse individuals' lives. And so we're also looking at this from a comparative perspective, not just across jurisdiction, but across different professions. So in the next slide, we will describe some of that. So we focus on 7 case study professions, and there are 4 in healthcare. So we're looking at nursing, midwifery, medicine, and dentistry. And then we have 3 professions outside of healthcare: academia, accounting, and teaching. And so those settings, they vary by whether they're in healthcare or outside of healthcare, because, you know, we really wanted to look at, some people talked about how healthcare is a very toxic environment to be working in. And so we want to look at what are some of the unique toxic features of healthcare and what might be shared with other professions. And for example, comparing nursing with teaching is very interesting in terms of it being largely a public sector profession, largely occupied by women. And so we want to look at some of those circumstances. Each of the professions also vary by gender composition, some of them being more traditionally feminine, such as midwifery and nursing and teaching, you know, to a certain extent, and some that are more traditionally masculine, even though they are feminizing, like dentistry, medicine, accounting, and academia. Leadership is also a cross-cutting focus because we're looking really at what can nurse leaders, physician leaders, etc., leaders within the professions do to be a point of intervention. And that is one of the areas of our focus, is to try to find promising interventions to improve mental health, thereby not having to go through leaves of absence and then return to work. So next slide. So I'm not going to go through all of these slides in detail. This is just to give you a sense of the largesse of this project. It involves over 25 investigators and 15 trainees at 16 universities. Next slide. And over 30 partner organizations. So each of the case studies has partner organizations that they're working with directly. And you can see the Registered Nurses Association of Ontario was there. And so for each of the cases, we are working primarily with professional associations and unions at the outset. Although we're interested in the perspective of regulators, they are not our primary partners. So it's important to note that in the work that we're doing. So next slide. So I'll go through in a variety of different stages our conceptual framework and our research objectives, so we can go next. And so we'll go through these rather quickly because I'm sort of building the conceptual framework as we go. So the framework that we have, we call it sort of an intersectional contextualized path model of mental health leaves of absence and return to work. And so the path there is the moving from mental health to leaves of absence and return to work, because we're trying to focus on healthy return to work, but not returning to the same toxic circumstances that led you to have a leave of absence. So we have all of those different pieces of that pie. And so we situate that path model within a broader context that, if you click through the next slides, we'll just walk through those.
Ivy, you don't mind
So
that I
one of the, no, go ahead.
because I'm tweeting as we speak.
So one of the things that we're trying to do is, first of all, we look at the individual and the context of their lives, you know, what their personal health circumstances are, because mental health affects us personally, but it's also affected by our context. So we're interested in individual level influences and impact, and particularly because we're taking an intersectional lens on this, we're interested in issues around gender and sexuality, your age and your ability, issues around indigeneity and your race or racialization. So we're really trying to kind of unpack those. And those exist both at an individual level as well as a broader family level. And then we're also interested in the work and organizational level. And if you click one more time, we'll look at the broader system and societal level. So that is what the different layers of context are influencing the individual and that path between mental health, leaves of absence, and return to work. So this conceptual framework has emerged out of a lot of research that we've been doing to structure our questionnaires and our survey with different professional workers and moving forward to try to unpack and tease apart all of the influences on that path, but also the impact of mental health leaves of absence and return to work to oneself, one's family, one's work and employers and coworkers and organization, etc. So that in a nutshell is our conceptual framework as we've developed it. So we go to the next slide, we are applying these to the specific research questions that we have, which we've clustered around sort of those three main areas. And so our first set is really looking at issues of the mental health. So really kind of understanding the mental health experiences of professional workers, and then to understand those layers of context, how that impacts the mental health of workers, personal, familial, work, and organizational. And then we get to questions around leaves of absence. So we wanted to identify which of these factors, again, personal, family, work, and organizational factors, influence the professional worker's decision to contemplate, to think about, taking a leave or actually taking a leave, and trying to understand what are the antecedents to taking a leave, what are the precursors, what's the proverbial straw that breaks the camel's back to making you leave, and what are the barriers and facilitators to actually to contemplate, to ask for a leave, to and to take that. And slide, we get into the questions.
You're breaking.
We hope that the leave of absence is more of a temporary one, so that enables you to come back to work, but in a way that the work has changed in some way or shape or form. So again, return to work to identify the personal, family, and work and organizational factors that facilitate or create barriers to return to work. And here's where we want to identify those interventions that facilitate a healthy return to work. We're interested in the impact of this whole process on a variety of different outcome measures, because we feel that this might be the way that we can solve those interventions, to say that this is better for the professional worker, for the quality of their work, for their relationship with core students or patients and others within the organization. And so that is ultimately where we're headed, but we need to understand and tease apart the elements of this path and contextual model process going forward. So next slide. So as I mentioned, we are questions and in the framework. And we want you to understand that we're thinking of gender not just in terms of whether you identify as male or female or non-binary, but it's beyond that. It's what are at those multiple layers, the family and the work layers, what are some gender norms and gender roles and gender relations? And these have become much more salient and explicit during COVID. We have been working from home, literally doing double work from home. And so it makes that double work that we're doing that much more apparent. And so we want to understand how gender influences this path between mental health, leaves of absence, and return to work, and how it impacts on your ability to negotiate and to contemplate and take a leave, and then how interventions need to really appreciate all of these dimensions of gender and how that impacts on the path to healthy return to work. Next slide. So I'll go through some of our methodological approach, which has multiple phases and multiple methods. And so on the next slide, we try to sort of visualize those in a bit of a sense. So to first of all start off, that we did a partnership development grant, which is sort of a fancy name for a pilot study. And in that pilot study over the last couple of years, we undertook a scoping review of the literature, and Melanie will speak to that. We did some pilot surveys and interviews with workers. We undertook some stakeholder interviews, and we also commissioned an analysis from Statistics Canada, because we wanted to see what do we already know, because we wanted our work to be value added. We didn't want to kind of recreate what was already known. So for this full, what we call a partnership large team grant, we are building on those different elements, doing additional stakeholder interviews, adding some explicit document analysis in addition to the published literature. And as we see there, we're going to be doing surveys with workers as well as interviews. And so that really depends on the worker, what their preference is. Some people don't mind participating in surveys, and we're trying to keep ours short. And some people prefer to have, to talk more about their story, and we'll be doing that in a variety of different interviews. We're going to do some follow-up Statistics Canada analyses, as well as identify some really promising practices and to study sort of pre and post. So we have another 3 to 4 years on the project, and we're really just building on the document analysis and stakeholder interviews that Abby will talk about, and we're about to launch into the worker survey and interviews. So next slide. So I'm going to, well, first of all, I will pass over to Melanie to talk a bit about the partnership development pilot studies. But I'll talk first a little bit to the StatsCan analysis. I've been working directly with folks in StatsCan, and this was, you know, to look at some of these issues across the different case studies. So when we did this comparative analysis, nursing emerged as some really things. So in the next 3 slides, I just want to kind of highlight what has been particularly unique about nursing and something that we want to explore a little bit. So in the next slide, so these are data that were analyzed by our colleagues at Statistics Canada. And they are data derived from the Canadian Community Health Survey, the 2013 and 2014 wave. And what we had asked them to do was to look at some specific questions around occupational stress and work context. And so we looked across our different case study professions. And as you can see there, nurses stand out quite dramatically. So these are draft findings. They haven't been published as of yet. And, but what was quite interesting, so our case study professional workers reported high, and this is rated workers. So that's the beauty of the Canadian Community Health Survey. You can compare our case study professions to others. Nurses reported the highest work stress, professors the lowest. So we wanted to kind of look a little bit more at that. That was that red bar. On this slide, the case study professions, especially teachers, there was a really interesting gender difference that we found for teachers and professionals. So even though their occupational stress is lower, it was very interesting to look at the unique differences within those professions. But here again, you see that the much higher ratings of occupational stress for nurses, and that's equally so as the case for male and female nurses. So there's something about nursing that's not just about the gendered nature of that work that we really want to try to unpack. And the next slide tries to kind of tease that apart a little bit further by looking at the different, you know, features of work, issues around physical exertion, skill discretion, decision latitude. And what was really interesting here, and because the nursing sample was the largest, we suspect that nurses are really causing this profession, so higher job strain, physical exertion, and lower job authority. And so we can say that from a perspective, but we're interested in taking the next one quite specifically. We didn't have the sample size large enough, for the things that we're looking at in our own survey for nursing. So I'm now going to pass over to Melanie, who will walk us through a scoping review that was done. And so I'll have you do that, Melanie.
Thanks, Ivy. So yes, so as another step during the pilot, we've done this scoping review. So it was under Kristen Koval leadership. So it was to look if what we have in the literature about accommodations for nurses when they return to work. So at the next, so the background, as it's been a bit mentioned by Ivy, we know that nurses engage in the practice. They are confronted with a lot of challenges and demands, and then we have increase in the mental health problems as well. And we know that they just not have, you know, problems with burnout, but they can have anxiety, stress, depression, use of alcohol, drugs, so, and then lends to a leave of absence. So that one was, so one we want to know, it's what we can do for them at the return to work. So the aim that we're looking for, it was to look the risk and factors associated with nurses developing mental health issues. And we wanted to map the literature about accommodations for nursing returning to work after a leave of absence. And just as well, we know how difficult is it just to disclose, you know, for nurses. In the literature review as well, we've seen sometimes that there are few benefits to disclose. So it asks a lot of courage, you know, from nurses to be able to disclose, take a leave of absence. And then we want to know what we can do, what we have in the literature to support the return to work. So they were not as much as papers that we found. And this publication is open access, so you can have access if you want to have more details. But we were able to find 6 studies, all from US. 4 was quantitative and 2 was qualitative during the scoping review. And from those 6 studies, we were able to see 3 major themes, so 3 major kind of accommodation. It was an alternative to discipline programs, peer support, and return to work policies, procedures, and practice. So I will go over each to explain a little bit to you what programs or kind of initiative that was offered. So alternative to discipline programs, it was focusing primarily on nurses with substance use disorder, and it was use like a TIC to do an intervention for them when they come back, like a conferences, you know, to monitor them. So to try to have programs that they are not punitive. So the purpose of this program was to remove nurses from practice during the acute phase of the disorder, provide treatment, and then allow the nurse to return to practice in the structured, monitored environment. So it's a voluntary, not punitive programs, and it's developed and facilitated by a State of Board of Nursing as an alternative to the traditional disciplinary approach. Another, so this care monitoring of nurses, it can be done by the end nurse, by someone else, you know, on the floor from the organization, and then it can be done through doing a contract to see, you know, the hours of work that she will do, that she will have access to the narcotics. So those programs, as I said, was very focused on the use of narcotics or use of any kind of narcotics on the unit. So it was not about burnout or anxiety. So those alternative to discipline programs. So it was very narrowed down on this. So the next one, it was about the peer support. So the peer support is usually designed for the nurse to guide nurse with alcohol and substance use. So again, the articles that we find discuss about this. So we were not able to find anything published about the effectiveness of program for returning to work, you know, for burnout. So it was again focusing on this, and it was most specifically the support from nurse managers and sometimes other colleagues to facilitate the return to work, because we know that there is a component of confidentiality as well when a nurse is returning to work. So often it's difficult for the other persons to provide support that they might not know why this person left the work as well. So in the next slide, we find as well that they have return to work policies, programs, and practice. So by the organization, so it can be the best practice, the guidelines, prevention guidelines that has been developed and adopted for the nurse when they return to work. So when we finished this literature, so our main conclusion was that what we found, it's mainly focused on alcohol use and other substance use disorders. So we found that it was, again, highlighting the need, you know, to go further with the study that Ivy just presented and to look what else can be done, because we know that nurses are living for mental health issues, not only related, you know, to the use of alcohol or other substance, but we do have other issues as well. And then we need to have good interventions to focus on these issues as well. So in the next slide, we're currently working to know more about what we can do differently with the interview of stakeholders, and Abby will discuss a bit about this, and to looking for as well as any innovative initiative that has been done in some organization, so that we can find others accommodations and for different issues as well. So in the next slide, I think that we are going with AB. Thank you.
So I'm going to speak to you about emerging findings that came up throughout the stakeholder interviews and that we've been seeing recurrent in the literature. So I'll start. We've done so far 3 stakeholder interviews, and we're going to do more. And what's come up many times throughout the stakeholder interviews and in the literature review is that the main mental health issues are around stress, burnout, depression, anxiety, PTSD, fatigue, and substance use. And many of the causes for that are high workload, understaffing, job characteristic, exposure to traumatic, stressful events, workplace violence. So this is violence from patients and also interpersonal violence. So between colleagues and also our managers, we see a lot of bullying also between peers. Poor relationship with managers and lack of managerial support. So now nurses are having, managers are having to manage multiple units, many nurses. So there isn't that relationship anymore with the managers. Managers don't know their employees really well, and their employees don't know their manager. So it's kind of hard to provide that support for their staff. The work context. So many studies have been done in one specific work context, or some have also compared different work contexts. And what comes up a lot, and what came up a lot also in the stakeholder interviews, is around long-term care. So we're seeing a lot of issues in long-term care. And this is mainly because long-term care has a lot of has poor working conditions. So a lot of understaffing, it's a difficult patient population to work with, lack of resources. Long-term care is very underfunded and is also an undervalued place. It's not as valued as acute care. Also, other work settings that do come up are ICU and ER, and this is mainly because they're exposed to a lot of traumatic, stressful events and workplace violence. And then we have the double caregiving responsibilities. So we're caregivers at work, but we're also expected to be caregivers at home for our children, for our spouses, for our relatives, for anyone and everyone. And then, of course, the pandemic has just exacerbated all these issues. So it's gotten a lot more complex for many reasons. First of all, the fear of contaminating our family, of bringing the virus home. So a lot of nurses have been isolating from families. The stress, the anxiety around the lack of PPE. We don't have the adequate resources to protect ourselves and to protect our patients. And then there's also the compassionate fatigue, the emotional fatigue that comes with having to provide care to patients who are alone, who are suffering alone because there was restrictions on visitations and things like that. So that really does take a toll on nurses' morale, and it just makes everything more difficult. And then if we go to the next slide, I'm gonna talk to you about different other points. So our project also looks at mental health supports at work, and we're seeing that there's not many mental health supports at work, as Melanie highlighted, and as they found in their scoping review. And the focus is more on the individual rather than on the organizational context. The problem with that is when the individual takes a leave of absence, usually it's because of, the difficult work environment. However, most of the time when they come back to the same toxic work environment. So there's a problem there. However, it's not changing. Next point is that managers are not well equipped to deal with mental health issues. They're not trained, educated, or we don't really talk about mental health issues as much as we talk about physical injuries. So that's another problem. And then we have the poor uptake of findings, recommendations from governmental report. So we had the Mental Health Commission and also the Psychological Safety Standards Act. Those are reports. They issued recommendations for a workplace to implement different recommendations or outlines to promote a healthier work environment and to promote mental health at work. However, these recommendations are voluntary. They weren't mandated to be implemented, and no one was really following up to see if these recommendations were being implemented, if they were working, and things like that. So it seems like mental health is voluntary. And then finally, taking leave is very difficult. I don't know if you guys have ever filled out a WSIB claim, but those are very focused on physical health. One of the questions being, what caused your injury? Well, when it's a physical injury, I can say I slipped and fell and broke my arm. But when it's a mental health injury, it's usually an event after an event after an event, and the accumulation of events then causes issues. So it's hard to pinpoint what the exact problem is, but they want to know the exact problem. And then our study also addresses presenteeism and absenteeism. So there's a very high prevalence of both among nurses, and this comes up a lot also in the literature. And they're highly addressed topics in nursing literature. There's a high rate of sick leave also, and it's very difficult to take leave for mental health reasons, like I said. So if we go to the next slide, you guys now know that our project also looks at mental health, but from a gendered perspective. And that's really important in nursing, because nursing is a very gendered profession. It's a feminized profession. And just by looking at the way nursing has developed and the history of nursing and how nursing, you know, initially it was a vocation, we were caring from the goodness of our hearts. And so the history of nursing has highly influenced the way nurses are treated as a workforce. And they're not treated as equally as the male-dominated profession. And this is very visible recently, for example, with the Bill 124 that was issued by the Ford government. And then there's the pressure for presenteeism. So presenteeism is coming to work even though you feel ill. And there's a pressure for that for many reasons. So first of all, nurses do have a pretty significant salary. So sometimes they are the higher earners in the family, or they are the single earners in the family. So they feel the pressure to need to go to work. And a lot of times nurses, they're not full-time, they're part-time. So they don't have sick time. So it's either they have no choice, they have to go to work. And then finally, there's the double and triple caregiving responsibilities. So as women, we're expected to care, we're expected to be the caregivers for our children, for our parents, for our spouses. So it's like we're nonstop caring, and it does take a toll on us at some point. I'm going to talk to you in the next slide about a recent key study that has been done. This was at the University of Regina in collaboration with the CFNU. And it looked at, the aim was to better understand probable rates of traumatic exposure, mental health disorder, and burnout among a large pan-Canadian sample of nurses, and to obtain information about mental health training effectiveness, and mental health help-seeking behaviors among nurses. So this was a pan-Canadian study, and they did a survey across nurses across all Canada, and they really wanted to look at mental health disorders among nurses, because there was no data really about that, recent data. And they also wanted to look at what's being done for nurses right now for mental health. And the goal was to raise awareness of mental illness among nurses and see better support put in place for them. And the findings really relate to what I just said, but it would be, if you guys want to go check it out, it's really interesting. And yeah, that's my part. I'll pass it back to Ayoub, I think.
That's super. Thank you so, so much. And it really is important to kind of understand what it is that we know in the literature and we don't know as of yet. So as I mentioned at the outset, we have some next steps that we'd like to let you know about. We are going to be undertaking some surveys with workers as well as interviews. So in the next slide, I can explain a little bit about what those are going to look like. And when we had this conversation towards the end of July with Doris, we were really excited about doing this because we figured we would have our survey up and live and ready to go. The survey has been reorganized and really tightened, and it has to go through those 16 ethics review boards just as a modification. So we're hoping that it will be ready to go in approximately 2 weeks. So that will be coming soon. We did a lot of pilot testing of that interview, of the survey, to make sure that it's around 15 to 20 minutes. We're really trying to kind of just, tap some of the high level findings, and that we're really utilizing interviews to have those really in-depth conversations with you, because it may be that you have had more than one leave, and you've taken a leave and you've come back and things haven't changed, or you've ended up changing jobs. We're also really interested in how you adapt at work, how you find accommodations at work or move laterally within work. And so we're interested in all those permutations about how you manage poor mental health at work. So this visual is sort of like the path that our survey takes. These are the different modules of the survey. And so this will apply to all of the different different case study professions that we're looking at. So our questions that are common to all of the case study professions, and then we have some very nursing specific questions that we'll be asking you. The next 2 boxes is that we go through looking at your mental health, burnout, absenteeism, and work stress and non-related stress. Although when you're working, that's all very blurred. We're looking at it now, and then we're asking you to reflect on this in February before COVID became a huge thing. So there's going to be repetition in the questions. We're trying to understand what impact of COVID on these specific circumstances. In part, you have to launch our survey in March before everything broke. We initially had a conversation, so I'll get to kind of see how everything turns out. And then as it went on, we started realizing what a huge impact COVID was having on our 3 main factors: mental health, leaves of absence, and return to work. And return to work is really complex. I wanted to be able to add these questions, and then we get into, again, those mediators or accommodations that you request or you make yourself. You somehow navigate through the system. And then what have been your experiences with leaves of absence, return to work, and what has been the impact, again, on yourself personally, on your family, on your work, etc. And then we get at, we usually leave the demographic questions for the end. And then we will do this survey. And because we have another 3 to 4 years on the study, some of you may be interested in doing a follow-up survey in a year or 2, where we can look again at how COVID has played out and what has been some of the impacts on that. And then that will also be a place for you to also volunteer to do the interview. So, but if you want to do an interview, you can absolutely literally sign up today. You can send an email message to the hpw@uottawa.ca account, or you can send a message to me. The interviews are going to be taking approximately 40 to 60 minutes to allow us to get into these in-depth stories. The interviews, you will receive an honoraria, but we won't be doing that for the survey. And we will have more information. For example, Doris invited us to do a blog, which Abby led the team in writing. So that's been posted, and so that information will be on our website. We're just doing a few little tweaks, and that should be off and ready to go tomorrow with some additional information. And we'll post this slide deck there, as well as where it will get posted on the RNAO website. So that is a bit of a background of the study. What we hope to do, we're really all ears. We really want to have your stakeholder interviews that we should do. What are the types of avenues we should explore further? And yeah, anything that you would like to share, we're really keen on engaging you in at this point. So thank you so much.
So maybe people can indicate in the chat if they have questions, and then Susan, you and Tim can guide first, second, etc. I will just ask you a very general question. What has changed, if anything, in the last 15 or 20 years, Ivy? I mean, we know
I
that
think
female professions suffer much more than others in nursing, some of these aspects. So is there anything that has changed both in terms of negative or in terms of a light of hope?
Yeah, I'm an eternal optimist, and I actually feel that although there's always kind of 2 steps forward, 1 step back, right? And you guys know that because you're on the front lines and you're negotiating, just trying to change the working, the working conditions. The reason why I'm hopeful is that there's more attention paid to issues around gender, and nursing and teachers are.
Can't hear.
I think she's frozen.
Okay.
Are 2 of the most feminized professions, are the predominant health workers, right? So because of gender, because of this increased focus on gender, I think that there's more attention to this. That's number 1. Number 2, I think that there's more attention paid to issues that they call psychological health and safety at work. And the Mental Health Commission has been really pushing that. They've developed this psychological health and safety standard. As of yet, that standard does not take gender explicitly into consideration. It must, because I can't imagine 2 things more gendered than work and mental health. So if you're going to have a psychological health and safety standard, it has to take gender into consideration. So we're very hopeful that it'll move to that point. But because of those 2 issues, that's why I'm hopeful. And I'm hopeful, for the healthcare sector, in part because everyone has been paying attention to the health workers during this crisis. So this is, either, a silver lining, to this very black rain cloud, or, take these lemons and make some lemonade out of it. I'm hopeful that we'll be able to move a leap forward in terms of the quality of work and the attention that we are putting on mental health at work.
Thank you. I'm adding on the line, but I will just say, to add to that, I'm hopeful because I think that in the last 15 years, 10 for sure, nursing and nurses have become way more powerful. Way more powerful, both in organizations, in the media, needless to say, at least in Ontario, big time, way more powerful. And I think that pushes also the agenda.
Well, the chat box is very, very busy. Lots of people interested in signing up for interviews and participating in the study. Lots of gratitude. People expressing frustrations with what you're saying, that with the status is. Some comments about, being in independent practice, the added challenge of that possibly. Also a comment about people not being supported to maintain their scope of practice. Comment about disparity of the resources that are available in different sectors across Canada and also in private companies. One link was shared with the for Ontario Human Rights because there is some, they're addressing return to work. So those are some of the comments. I'll ask a question from Sue. Have you done any reading on magnet hospitals in the United States? Workplace environment is a factor to be given magnet status. There is some input from employees and then works to establish a status that may draw their employees to want to work with that hospital. Do you know of any other ways that employees are seeking employment who can access the work environment in advance of becoming an employee here in Canada? So any thoughts on magnet hospitals?
So,
Yeah, so I'll go ahead, Doris.
well, I'm pretty familiar with the literature because of all the work of PPSOs, right? I don't think they have proven it. I don't think they have proven themselves so much as places where there is less mental health amongst nurses, for one. So there is a lot on the branding sometimes, although less than before even on that. And I think someone answered, I think maybe Majin was, and also I, on the issue of BPSOs, has proven a lot more in terms of actually a place that, because I think the person that wrote was asking to check out places here when you go to seek employment, to check for good places. So one clear way is the issue of BPSO, because it means they're putting actually an effort to improve both work environment and patient outcomes. So they actually do something, right? Concrete on that.
And actually, just Doris, to build on that, I would say that given the response that RNAOs had from BPSOs, and especially the nurses involved, it would be very interesting to look at a BPSO organization and how that might impact nurses' mental health versus one that isn't.
Very good point. Excellent point. That's for another study. But even here,
well, no, actually, what we are trying to do in our next phase is we are trying to identify, case studies.
Very good.
And so initially we were saying, maybe we'll do some case studies at those organizations that have adopted, the psychological health and safety standard. But then we were told, well, that hasn't really translated into policies on the ground. And as we've dug a little bit more, we've found that that may not be the most promising. So we want to hear from you about promising places that we can look to and then study that, with some really institutional ethnography, and come up with some.
Excellent.
So
so I think can look also to add to that on places where the CEO of the hospital is actually a nurse, because I bet you that will make a difference. So look at a place like Hamburg, where you have the CEO of the hospital, the president and CEO is a nurse, Barb Collins. Then you have Vanessa, who another person that probably is pushing issues. The other is Natalie, which leads the BPSO with Comelia. A whole bunch of, I'm sorry to say, women that are trying to push an agenda in, quite frankly, a world of male CEOs for the most. And it's very fascinating to watch them. So to do institutional ethnography, but also participatory ethnography, and speak with some of them and buddy with the nurses on the ground, I think you may find interesting things.
We had a very interesting knowledge exchange call today with our BPSOs in the hospital sector, and this was actually a question that we had for dialogue around assessing and supporting the mental health of the staff. And it was very interesting to see the similarities that organizations had, but also some of the really unique programs that were in place to help support. This was in the context of COVID, but really interesting to see some of the really specific strategies that organizations were utilizing to support their staff and acknowledge the challenges that they were experiencing. And that was with our BPSOs in the hospital.
Yeah, and it will be interesting, Ivy and Tim, to look, I don't want to take the time here, but to connect the dots with what Heather and Imagine were talking, because we do reports, right? They report to us. It never actually occurred to us, quite frankly, to ask about issues of how do they tackle. And so we could start to put some questions that can ongoingly, also longitudinally, put some thinking into that, because even by seeing the questions when they need to report, that triggers them to think differently about tackling some of these issues. So that can be very good to have that conversation.
Yeah, absolutely. Anything around sort of accreditation criteria or the like is intervention, because as you say, when they're being asked to respond to a particular issue, they'll go, oh, this is important, we need to do something about that. Then they will look into, well, what guidance could we provide. And so that's some of the work that we're trying to do as well. We did some of our team members did a policy partnership with Health Canada, bringing to them some advice from a sex and gender perspective around mental health at work, and we created a toolkit about how is it that we might be able to attend to intersectional issues, so not just sex and gender, but racialization, etc., and how that might be different for people and how they experience, for example, microaggressions, or how they might experience work-life balance differently. And we targeted those to managers to kind of say, here's some important information and some tools, you know, that you could do to implement some policies and have conversations, and that could be, you know, part of your, you know, performance assessment. But again, the more that you make these issues explicit and part of any type of assessment or measurement, then people start paying attention to it, and we hope we'll have some positive impact.
Yeah.
Mm-hmm. You know, it is really also important to look at the healthy work environment BPGs, best practice guidelines. A few people have commented on them. And when you talk about a case study, that would be also a very interesting case, because the healthy work environment best practices cover issues like collaborative practice, leadership, staffing, diversity, what else? Anyway.
Well, we had, but here is an interesting thing linked to that. So we did a guideline on fatigue, nurse fatigue, which is linked directly with issues of, and this was by the request of CFNU. So actually Linda Silas was the co-chair, remember, Imagine?
Yes.
And you take the workplaces, it's one of the BPGs that was used the least compared to leadership or professional practice, or so there is something intriguing to me, and I think that it will be good, your research, to start to kind of push the agenda further than what I perceive is being pushed, Ivy, because we know a lot about some of these aspects, but I am always puzzled of why is it that nursing, right, runs away from mental health in nursing, right? So the issue of fatigue.
Well, but it's not just nursing. All health workers run away from mental health. This is the reason why we included professions outside.
All equally, female or male health professions?
Oh, that's what we're testing, right? But that's one of the things we
I bet
find
you my life
that
that's not the case. It's because as mothers, as this, as that, again, it's the gender piece, right? Put up with that. Put up with that. And if you don't like it, we will find someone else. And during COVID, just so you know, we heard from nurses directly that they were once again being told that if you don't like it, take the example of a nurse, doesn't matter where in Ontario, that felt that was unsafe with the mask that was using, went to the manager, and it was in one of our webinars, by the way, too. And the manager said, this is the way it is. And the nurse said, well, I didn't sign for it. And was told, yes, you did. And the nurse, thank goodness, right, said, well, what I signed for is to take care of people and to nurse. I didn't sign for being asked to go unsafely, right? But she was pushed to, yes, you did sign for it. It's like if you don't like it, and I remember in the 90s with the health system transformation back then, and replacement and restructuring, etc. Right? If you don't like it, we will find someone else. That attitude, right? At the time that you all said, nurses many times are the main breadwinners. So no, they cannot just take off and leave. So they leave sick. That's what they do.
I see a question here about younger nurses, that the CFNU study focused on younger nurses. And what is your perspective on whether younger nurses may be more prone to taking leaves of absence? I've just lost the question here. So I
Well,
don't
and this
know.
is something that we are going to be looking at most definitely. So we ask questions about years in your career as well as your age. So we really want to understand, you know, what are the perspectives, and the survey will be a cross section. We'll be able to compare, you know, nurses, you know, of different age and different lengths of time in the career. In the interviews, one of the things that we hope to use, and it's not for all interviews, but that we're going to kind of implement what's called sort of a life course calendar. And all that is an Excel file where you list the years and what sort of significant events have happened to you in your years and what were the precursors to you taking a leave, what was happening in your work, what was happening in your family life. And we can kind of see that visually. And we implemented that for a small pilot study of academic women. And they found it really helpful to kind of see it all together. So it helped them to kind of understand, well, that's all the stuff that was going on in my life before I had to take a leave. And it was somewhat therapeutic for them to see that. And so we do want to see that life course perspective as well, which is how you get at those nuances of gender. So gender is not just comparing men and women. That's a sex difference, you know, approach. We're interested in that, but we're also interested in, are you the main breadwinner? You know, is your salary the largest salary in the family? So we'll be asking about, you know, just honor ratings, you know, is your salary 60% or 10%, you know, of the family, or 100% if you're a single mom or a single parent. And so we really want to be understanding all of those differences of how gender plays out in both your personal life and your family context and in your work context. So we're trying to kind of see that through different layers.
Great.
You
I
know,
to just interject for a minute, just to let you know that we've got 8 minutes left. There are lots and lots and lots of comments.
we will bring you back.
What's that?
We will bring them back.
Bring them back. Okay.
We will.
All right. We could do a part 2. We have a webinar in a month from now, or in some other way. And so you did say that you would be willing to answer questions. I'm wondering, there is just a practical question. How do we sign up? If you could please reinforce that. And then also, if people want to have their cameras on for the cheer, maybe we can start to get that organized as we kind of sum up here.
And Ivy, we can continue the conversation, but I suggest that you also add in the future the other side of the coin. I will send you a link to my dissertation in 210, and was not intended to do anything about gender, but gender happened because the dissertation was about the social construction of caring in nursing. But being a nurse sometimes is a burden, but many times it's a strength in the family. It positions, it came as a key theme by nurses. It positioned them as powerful in the family, as the person to go to ask questions, as the one that can problem solve. And I think we need to help nurses in terms of both tackling the heaviness of nursing with some of the strengths that can bring them that balance or that capacity to put resilience in their lives, with some of the natural strength that nursing gives them in their own communities. It was very interesting to me to see that, how it's not all heavy, you know, how it really positions them in their family and in their own community in a very amazing way, in many cases.
That's a good point.
Yeah.
Absolutely.
I saw a comment from Paula, I think Paula is somewhere here, about the issue that, employers can tell you, well, if you don't like it.
There's 50 people to take your job.
Exactly, that is actually it's bullying. Actually, it's bullying. That's what it is. but you see, when you're the only breadwinner, they're afraid to take that up. Some do, right? So the alternative, it will be interesting in your questionnaire or in the surveys when you talk with nurses and they tell you that. So what do they do, right? Because sometimes perhaps what they do is, I'm taking off sick because I had it, right?
Well, that's what are your degrees of freedom that you can make a change, right? Do you try to move from one unit that's really you're experiencing bullying to another unit? You know, do you do that? It's not just, so we're not just interested in you taking a leave. I mean, that's part of what we're interested in, but there's all these things that you do to avoid having to take a leave,
To
right?
protect
So
yourself.
those negotiations you do, we're very interested in those. Yeah.
Mhm, mhm. And it is interesting to look at. I go back to the age, the youth. There's a number of comments about young people, what they learn in school. They're not as resilient, or maybe do they speak out more? Do they tolerate less in the work environment than older nurses? I don't know if you'll tease those out, but very interesting kinds of issues that relate, I think, to not gender, but generation.
Well, and also imagine to the issue of what should we be doing different in school to actually prepare people to not put up with that.
Yeah, well, and I think they are. And then what you hope people don't say, oh, they're less resilient, because they will speak up. It's a strength.
You're right. You're right.
That's
right.
a form of resilience, right?
Exactly.
I'm not putting up with this.
It's a challenge when you're the only voice that's speaking up, though.
I guess.
Oh,
Very
yes.
lonely. And something I really wanted to flag, which is really imperative, is the trend of nurses not being managers in clinical settings. Because
Yes.
few nurses, can understand another nurse. So I just want to flag that, because I think that's a real issue. Nurses are not understood that they're knowledge workers. They look at them as a bunch of task achievers. And that's an ugly reality, but when you speak up, you get to spend a year, like I have, sitting out here waiting to get another opportunity. But I'm not going to change my voice, and I'm not going to dumb down my resume. So I'm looking forward to my interview. Thank you.
Excellent. We're looking forward to it too.
It will be interesting, Ivy and Tim, that you interview generations. Like, there are several, and we can give you even names. We can approach them and ask if they're interested, of daughter, mother, or son. You know what I mean?
Yeah.
See if anything has changed, because this is as old as nursing.
Well, and some other research that we were doing in long-term care, we found a lot of that, right? Mothers got their daughters into the long-term care facility, and the daughters
Yes,
just
but
like, I don't know how you live with this.
But
right?
when you look at women abuse, right? You many times see that the mothers, right, actually say to the daughters, "Don't worry, it's going to go away. Maybe we as nurses are saying to the daughters that put up with this mess at work, don't make noise. It will go away. If you make noise, you will be." Who knows how we deal with that generationally? I don't have a daughter that are nurses. I wish I had, but it will be interesting to see.
No, it's very interesting. And to that point, I know a lot of, there were a couple of comments on issues around violence, and that's part of a poor mental health at work if you're experiencing violence. So we are absolutely as well.
So shall we close with a mass cheer?
The mass.
If everyone who's on camera, or if there's anyone else, there's room for 2 more people on the screen, I think. If they want to join the cheer.
Do we need to bring things to make noise?
Well, we can use our voices and our hands and anything else you might have.
Yes.
And I just wonder what the theme should be. Ivy, Melanie. Abby,
for nurses, good mental health.
Absolutely.
well, it's been a very lively discussion online, and I look forward to sharing some of the comments with you, team. People are very grateful and have a lot to say about this issue.
So Melanie or Ivy, if people want to connect with you, did you put your emails there, please?
Yeah, so you can, sorry, you can put that at hpw at uottawa.ca. It's on the slides. The website, we just need to do a few tweaks. That should be live tomorrow. And you'll be able to go there. So you can send a direct message at our Twitter at Prof Healthy, or send an email to hpw@uottawa.ca, or you can send a message to me, Ivy Bourgeault at uottawa.ca. And then you can also volunteer online.
All of the above sent to us and we will forward.
Absolutely. Sounds great.
Okay, talking about gender, not that males don't cook, but in my house they don't, they do the dishes. I cook. There you go. That sounds good.
That sounds
Okay,
great.
this
So
is
you can start us, Doris?
Yes. Cheers to Ivy and her team that will help us attain better mental health for nurses.
Yay!
Very cool.
Thank you very, very much. Amazing presentation. And for real, we will have you back. We will have you back when you have when you have done some of the interviews more, and also when you have done the institutional ethnography. That will be fascinating.
Yeah, absolutely. So any idea that you have about places for us to do that, that would be great. And we're happy to come back.
Yes, I will connect with my IABPG team and with my policy team and send you an email. But it strikes me that Humber is one. I also think you need to look at maybe some in long-term care. Let's connect with that.
Okay.
Yeah, yeah, it will be.
Thank you so much, Ivy, Melanie, and Abby. This is excellent work. Thank you so much.
Thank you.
Thank you. Bye.
Thanks,
Thanks
bye.
everybody for joining us.
Thank you all.
Great to have you as always.
Thank you. Take care.
Take care.
Bye.
Thanks.
Thank you.
Bye.
Wow. Bye. See you soon.
Ciao, Paula.
Ciao, Doris. Call me sometime.
Mask. Wait.